Hello, I'm Rahul, a junior doctor in the UK, and today we'll be discussing AV blocks, the different types and the causes. Let's start off with first degree AV block, which is defined by an increased PR interval that's constant. Remember, the PR interval should be less than 200 milliseconds, and one of these boxes is 200 milliseconds. Also, there should be no dropped QRSs. Now, if we have a look at this rhythm here, we see that the PR interval is clearly wider than one box, so therefore we have PR prolongation. Each of these PR intervals are roughly the same, and each P wave is followed by a QRS. So therefore, this is first degree AV block. Now we'll move on to third degree AV block. We'll come back to second in a bit. So with a third degree AV block, the most important thing to understand is there's a block between the atria and the ventricles, and they're not communicating. So we end up with two different pacemakers. So for example, we might have one here. Now the SA node fires, and you get these regular P waves. And also this pacemaker down here fires, and we get these QRSs. Now they're both regular, but they have different rates. So let's have a look. So for example, between this P wave here and this P wave here, there are four boxes. 300 by 4 is 75. So therefore, the SA node is firing at 75 beats a minute. Now between this QRS and this QRS, we have 1, 2, 3, 4, 5, 6, 7. 300 by 7 is 42 beats a minute. So we call this AV dissociation. We see that the pacemaker below the block is firing at a different rate to the pacemaker above the block. So the criteria is 1, the P to P intervals are different to the RR intervals. Now, one thing I want to point out is that it's important to have a look at the width of the QRS. So for example, here you can see that the QRSs are quite narrow, so therefore it's following the normal conduction system. So the second pacemaker is always distal to the block. Now if the block is high up, it's likely that the pacemaker is near the AV node, so it can follow the normal conduction system, and we call this a junctional rhythm. However, if the block was lower, we'd have a pacemaker somewhere in the ventricles, and a ventricular rhythm leads to a wide QRS. So remember, a narrow QRS, we have a junctional rhythm. So we have a block that's high up in the AV node. With a wide QRS, we have a ventricular rhythm. So therefore, the block is lower down. Now, one other thing to point out is that sometimes the P waves can be hard to spot. For example, this is a funny looking P wave. And so the way to see it is that this T wave looks different to all the others. So whenever you have a T wave that's a bit too tall and you expect a P wave to be there, then suspect that there is one. So now let's move on to second degree blocks. So with second degree, you have one problem that's in the AV node. So we call this a Mobitz 1. And the other problem is below the AV node. So we call this a Mobitz 2. Now with the Mobitz 1 and Mobitz 2, you have non-conducted P waves, which you can see over here. Non-conducted just means that there's no QRS following the P waves. Now with the Mobitz 1, we see PR intervals that prolong. So you see this is relatively normal, it prolongs a bit, prolongs some more, and then you get non-conducted P wave. In a Mobitz 2, PR interval is constant, and then you get non-conducted P wave. So remember, Mobitz 1 is a problem of the AV node, Mobitz 2 is a problem below. Mobitz 2 is the one that you should really be concerned about if you see it. Now, sometimes a Mobitz 1 and Mobitz 2 can be quite difficult to tell apart. In this case, we can tell that this is a Mobitz 1, so the PR interval is somewhat normal, it prolongs, and then we have a non-conducted P wave. So this is a Mobitz 1. However, you could employ things like exercise, atropine, or vagal maneuvers. So for example, with exercise, with Mobitz 1, it should resolve it, or it should improve the block. Whereas with a Mobitz 2, exercise will have either little effect or it will worsen the block. Atropine will have a similar effect to exercise. Now let's move on to the causes. So the first cause are drugs. So common ones that you might see are beta blockers, calcium channel blockers like diltiazem and verapamil, and you have digoxin. The second one is increased vagal tone. So as an example, athletes with high vagal tone can often have a first degree AV block. They can even have a Mobitz type 1 as well. And the reason is increased vagal tone slows down AV nodal conduction. 3, we have coronary artery disease, and on a similar note, 4 is MI, particularly an inferior MI. And that's because with an inferior MI, the right coronary artery is affected, and this supplies the AV node, leading to dysfunction. 5th is idiopathic fibrosis. Now this is quite an important cause, especially in complete AV block. So in complete AV block, autopsy studies have found that about 50% of them are due to idiopathic fibrosis. Okay, so now let's move on to a question. So I'd like you to pause the video and have a go at this. So as you can see here, there's a P wave here, a P wave here, and a P wave here. Now I was hoping that you'd also assume that this is a P wave and this is a P wave. If this is true, then we have a 2-to-1 block, which just means that for every 2 P waves, one of them conducts. Now this is quite a special case because with a 2-to-1, it could be a Mobitz 1 or it can be a Mobitz 2, and we can't really tell the difference between them. And that's because we only have one PR interval per set to determine it. So we don't know whether the PR interval is prolonging or whether it's constant and we're getting drops. This rhythm here though is actually a normal rhythm, and these are U waves. Remember, U waves just represent delayed repolarization of the Purkinje fibers. Now the key to working this out is to look at the RR rate. So for example, from here to here there's about 1, 2, 3, 4, say about 5.5 boxes. 300 by 5.5 is less than 60, which is bradycardia. And in bradycardia, you often see U waves. Now, I hope this example taught you two things. The first is a special case of a 2-to-1 block, where we can't tell whether it's a Mobitz 1 or Mobitz 2. So in those cases, I would just label it as a type 2 AV block. And the second is that often there are other causes that can look like an AV block. So that's the end of the video. If you enjoy the content, please subscribe as there'll be more coming. Thank you.